Awesome.
Right.
Go for it.
So, welcome to your last, I think it's last lecture for the day. So we're going through endocrinology today. And apologies, I am still a bit sick, so if I have to pause a lot, don't be alarmed. My name is Monique. I'm one of the third years, and if you have any questions whatsoever, feel free to contact me, Facebook, email, whatever. Right, so what we'll be going through today. So this is the breakdown from our exam last year, but it's a bit different just because we had an end of year exam, but essentially endocrinology comes into one of the exams, and here's your discipline breakdown. And we have our exam breakdown on the right of all the topics we're going to be covering today. It might be a bit different for you guys, but I'll endeavor to cover everything. And just a pro tip, try to cover everything contextually rather than by discipline, just because it can be a bit difficult to understand everything and how it interrelates if you just do it by anatomy versus pharmacology versus physiology. Okay. And disclaimer, endocrinology is a super big topic and there's a lot of interconnected systems and there's a lot of tables and hormones to remember. So I'm going to be skimming through a lot of things. Just go back at the end and read through all the things you didn't understand and all the super complex things, because it's all quite high yield, unfortunately, and it's just a lot of content heavy information, unfortunately. So sorry in advance. But without further ado, we'll get into the content. So the endocrine system, it's all about how we sense our internal and external environments and how we adjust to how they're changing. And there's also the addition of how we organize reproduction. However, a lot of that's really covered next semester with reproduction. So we won't be going through a lot about growth, sexual maturation, and childbearing. That'll really be with next sem. All right, to get started, the endocrine system, it works very closely with the nervous system, and you need to understand the differences between the two systems. So essentially the nervous system, it's that compartmentalized closed system of cables that works a lot faster. So it's all your movements and your brain activity and things like that. Whereas your endocrine system is more so a slower acting but longer lasting circulatory system with hormones. And the two systems can actually work together, and they have to work together to form normal function. And they do this via three types of transmission. So first of all, you have your purely hormone system. So you've got hormone molecules released from hormonal cells acting on target cells. And then you've got your neuronal and hormone actions. So a neurosecretory cell, which is a specialized neuron, will act on a target cell via the endocrine system. And then you have your purely nervous transmission, which is where two nerve cells will traditionally transmit between each other. And to do this, we need hormones. So hormones are the chemical signaling molecule that's produced from one site and causes a particular effect at another. And we have three types, and we summarize it on the right here. You have your peptide and protein derivatives, amino acid derivatives, and your cholesterol derivatives. And the main differences in their synthesis, storage, and how they act a little bit. And you really do need to know the examples of each one and which hormone falls into which category. So just spend some time learning this table. And these hormones can have different forms of signaling. So you've got your autocrine signaling, where the endocrine cell will target itself. The endocrine cells can work across gap junctions. You've got paracrine signaling, where it targets nearby cells. Or you have endocrine signaling, where the cells target distant cells through the bloodstream. All right, so that was a whirlwind of what the endocrine system is all about. So we'll go to the particular endocrine glands now, starting from the top, so the hypothalamus and pituitary gland. Right, so the hypothalamus, it's anatomically speaking has three nuclei. You need to know the supraoptic, paraventricular, and parvocellular. I might see if I can get my annotation up so I can show you. So here's your three nuclei. And it's connected to the pituitary gland by the infundibulum, which is the stalk. And in that is the median eminence, which is this blood vessel system here. And that's got the portal circulatory system, which is super tiny, so that a few hormones from the hypothalamus can have a big effect on the anterior pituitary. It releases 8 hormones, 2 of which come from there's 2 that come from the paraventricular and supraoptic nuclei, and that's oxytocin and vasopressin. And these both travel to the posterior pituitary to be stored and released by that. And then we have our 6 hypophysiotropic hormones, and we'll go through what that means later. But essentially, these ones travel through that portal system and into the anterior pituitary and cause the anterior pituitary to upregulate or downregulate the production of different types of hormones as part of the hypothalamic-pituitary axis, which we'll go through in a second as well. All right, so the pituitary gland. Now, this is basically like the little brother or sister of the hypothalamus, and it sits in the sella ketoacidosis, which is a fancy word for ditch in the middle of the head. And it sits right below the optic chiasm, which is filled with the nerves that control our vision. And that's relevant later when we talk about what happens when there's a mass compressing one of those nerves. The pituitary gland has 2 parts, the anterior pituitary, called the adenomas, and that comes from the oral ectoderm or Rathke's pouch. And then we've got the posterior pituitary, which is the neurophysis, and that comes from the neural ectoderm or forebrain. And they're both supplied by the hypophyseal arteries. We get about 6 hormones coming from that, and we'll go through those ones later. In terms of histology, the anterior pituitary is glandular tissue, and it has 3 different subtypes of cells. So first up, you have your eosinophils, which make up 70%. And of those, we have somatotrophs and lactotrophs, which produce growth hormone and prolactin. So to remember that, you can remember AGP. Then we've got 30% basophils, which include corticotrophs, thyrotrophs, and gonadotrophs, which produce all of these hormones here. And to remember that, you can remember B flat, so AGP, B flat, to remember the subtypes of cells and the hormones they produce. And your last one is your chromophobes, which are these super pale cells here, and they don't really do much, to be honest, or that we need to know. And you also have some vascular sinusoids and a reticular network. Basically, the main point is to remember which subtypes of which cells produce what. So just know this table. The posterior pituitary, this one's pretty boring. It's just neural tissue coming down from the hypothalamus, releasing those hormones, vasopressin and oxytocin. And it's pretty much consisting of pituitary-cytes, which is glial cells, axons, and capillaries. Alrighty, so moving on to more the physiology side of it. So the hypothalamic-pituitary axis. This is what I was talking about earlier, but it's basically how the hypothalamus and the hormones that it secretes goes on to control what the anterior pituitary is secreting. And those hormones will go on to affect pretty much all of the endocrine hormones, endocrine glands in the body. Basically, just pay attention to what the hypothalamus produces and whether that has a positive or negative effect on the production of the corresponding anterior pituitary hormone. And you should be okay if you remember that. So this diagram. And how these hormones go on to work within the body is through a negative feedback loop. And as part of this axis, there's a 3-step kind of loop happening. You got 2 feedback loops. So we'll do it with an example to make life easier. So when we have our stimulus, for example, we're doing a cortisol loop, so stress, the hypothalamus releases a hormone. So this one's corticotropin releasing hormone. And that will increase levels of that, causing the anterior pituitary to increase or decrease the production of its hormone that corresponds. So this corresponding hormone is ACTH. An increase in ACTH will negatively feed back to the hypothalamus, decreasing CRH. And at the same time, it'll go down to the endocrine glands, so the adrenal glands, and cause that to produce its hormone, cortisol. And production of cortisol will go on to have its effect, but it'll also decrease ACTH and CRH production. Very confusing if you hear it for the first time, but just go back and read back through it and have another look when you have a bit more time. Just a quick reference overview now of all the anterior pituitary hormones and what they do and where they go. And same for the posterior pituitary hormones. Unfortunately, I don't have time to go through them, but you guys can read through that in your own time. Right, so a bit of pathology now. So the pituitary adenomas, one of the core conditions. Generally, they're adenomas, which is a benign tumor of the glandular tissue, which is why it really only affects the anterior pituitary glands. And it causes like a local mass that can compress nearby nerves. So for example, up in the optic chiasm above it, it can compress the optic nerve. And they can be hypofunctioning or causing compression and stopping production of hormones, or can be hyperfunctional and actually produce a certain hormone. And as I mentioned, the posterior pituitary is usually spared. So the presentation of these will really depend on what the hormones affected are supposed to be doing and whether it has caused an increased or decreased production. The buzzword, though, is bitemporal hemianopia, and that's because you're compressing the optic chiasm and you pretty much just have black spots in the edges of your vision. You can also get double vision from that as well. That's available on the drive. Cool. So yeah, you can get double vision as well. Treatment is surgery, and it goes up the nasal cavity, which sounds horrific, but it's better than brain surgery. And we just resect it. And if we can't resect it, we have to do things like hormone replacement therapy or receptor antagonists. A subtype that we sort of need to know about is prolactoma. Apparently this one's more common. So it causes an increased prolactin level and can cause some amenorrhea, galactorrhea, infertility, and osteopenia in women. And in men, it can cause erectile dysfunction. Other pituitary pathologies include things like panhypopituitarism, which is where you get no pituitary hormones, diabetes insipidus, where decreased ADH leads to polyuria and polydipsia. And that can be a production or a dysfunction problem. You can get syndrome of inappropriate ADH secretion, where there's too much ADH. And you can get Sheehan syndrome, which is a super rare complication of pregnancy, where a postpartum hemorrhage or blood loss can cause hyperperfusion of the pituitary gland and necrosis, and you'll have loss of those hormones. All right, so growth and growth failure, kind of a subset of hypothalamus and pituitary. So this is when you have growth hormone. So that's like a peptide hormone that has roles in cell metabolism, growth, and division. So it decreases adipose, and via the liver, it will increase bone growth and increase muscle mass. And so secretion, it peaks at puberty, but by young adulthood, it's down to 2 to 5 nanograms per milliliter and will keep decreasing with age. But on a daily basis, it's released in a pulsatile manner every 2 hours, peaking after an hour of sleep and with declines in blood sugar levels and exercise. So we get this sort of pattern in our growth hormone. And to do with it, there are 3 negative feedback loops. You've got your traditional growth hormone, negative feedback with growth hormone releasing hormone. And you've also got growth hormone, which can cause increasing somatomedin production. So somatomedin is produced by the liver, kidneys, and bones in response to growth hormone. So that can also negatively feed back to growth hormone. And growth hormone with somatomedin production can go on to produce somatostatin, which comes from the hypothalamic-pituitary axis and can decrease growth hormone. A bit confusing, I know, sorry. Here's a diagram to explain it. Secretion can be enhanced by things like sleep and exercise, but can also be inhibited by things like postprandial hypoglycemia, aging, and elevated IGF-1. So what does growth hormone actually do? Well, it acts via the JAK2 and SRC family kinases and causes transcription of genes that are required for growth and metabolism. And it has 2 different types of effects. Firstly, we've got those that are mediated by IGF-1, and these are the effects on cell metabolism and growth. So we've got them listed down here, but they're things like protein synthesis and bone lengthening and mineralization. And we also have some effects which are independent of IGF-1, which is like your anti-insulin actions. And that's things like lipolysis and decreasing muscle and fat uptake of glucose. So when things go wrong, so you can have too much growth hormone, which is usually caused by something like a pituitary adenoma, so a hyper-functioning pituitary adenoma. And you'll get 2 different outcomes depending on whether your bones are fused when it occurs. So prior to bone fusion in kids, you get gigantism, which is this guy here. And he actually didn't live too long, unfortunately, only reached like his 30s or something. And in adults post bone fusion, you can get acromegaly, which has some very distinctive bony features. And to treat it, we can either remove the tumor or we can stop the growth hormone having effect with things like dopamine agonists, somatostatin analogs, or receptor antagonists. One niche interesting point is that in Ireland, there's this frequent 2 mutations and they have caused increased level of gigantism in their areas, which kind of lines up with Irish folklore's reports of giants. So there you go. And then otherwise, we have growth hormone deficiency. So you can have idiopathic, which has no real cause in kids, but we just treat it with growth hormone injections. So that's your bottom left one here. And then you have Laurent dwarfism, which is where there's normal growth hormone, but we don't have enough sensitivity to its actions. So we've got the right picture here, and you can see the difference between the two. In addition to growth hormone, there's actually some other hormones that we need for growth. So in thyroid hormones, they set metabolic rate and things like that. And if we don't have enough thyroid hormone as a baby, we get cretinism. We need glucocorticoids, and that can be implicated in things like Cushing's and things like that. We need our testosterone and estrogen for our pubertal growth. So if we don't have that, we're going to have problems with sexual maturation and virilization, things like that. And we need insulin. And if we don't have insulin as a child, or we have a receptor defect, we can have leprechaunism. Assessing growth, basically we just use things like charts, history, and examination. But the main point is that if growth is abnormal, we have to consider all possible causes before we just jump in and go straight to trying to treat it. Alrighty, the thyroid gland. So anatomically speaking, the thyroid glands located between C5 and T1 underline the sternohyoid and sternothyroid muscles. It wraps around the cricoid cartilage and around the tracheal rings, sorry. And its isthmus lies between your second and third tracheal rings, which is this part here. Vascular supply, the superior and inferior thyroid arteries. You can see how vascularly rich it is. So you don't really want to have blood loss there or cutting it or anything like that. Embryologically, the thyroid actually forms the floor of the primitive pharynx and then descends into the neck to lie in its anatomical position, which is where this pyramidal lobe comes from. And not everyone obviously will have one, but if it is, it's just a benign remnant. And the clinical correlate is that with goiters, they can't grow up because of the sternohyoid muscles. So goiters will always grow downwards. The thyroid gland produces two hormones, T3 and T4 of interest. They're both from amino acid tyrosine, and 90% of the output is T4, which is the prohormone, and the rest is T3, the active form. It's secreted in response to things like cold, stress, or circadian rhythm. And conversion of T4 to T3 occurs via type 1 deiodinases, which are in target cells. And they go on to impact things like heart function, digestion, growth, muscle contractions, and basically just energy and metabolism. And obviously we have our negative feedback as well. The other niche point to know is that the brain needs to maintain constant levels of T3 because it's needy. And it does this via type 2 deiodinases receptors, which are in glial cells. I really can't say deiodinases today for some reason. So synthesis and secretion. This is one of those complicated ones that's probably worth spending some time on. But essentially, simultaneously, we're getting thyroglobulin being produced in like the Golgi apparatus and ER. And at the same time, we've got iodide being brought in and translated into iodine. And these two go into the colloid. And iodine will attach itself to tyrosine, forming DIT and MIT, which is basically like subsets of thyroid hormone. And then they will be linked together to form T4 and T3. And note how we're still in the colloid. And then it'll get kind of endocytosed out with some of the colloid into these little vesicles, moved through the cell. And then when they get the signal, they will be exocytosed as T3 or T4. And remember, it'll be mostly T4, which will later get converted to T3. There is circadian rhythm, but it's not really that big a deal. Alrighty, so storage and transport. So the hormones, as we just saw, are stored in colloid as iodinated thyroglobulin. And there's enough of this in the follicles to last a few weeks. So if we don't have iodine in our diet, we can last a few weeks before we start getting hypothyroidism. Transport is mostly by the TPG, with 70% of it circulating bound to TPG. 10 to 15% of the hormones bound to transthyretin, and albumin binds the rest. And then, so what do these hormones go on to do? Well, once T4 is converted to T3, it can go on to cause all of these different impacts. So growth, central nervous function, metabolism, which is where the energy effects will come from, BMR, and cardiovascular. Basically, the main point is that with the metabolic effects, most of these fuels go on to power the sodium potassium ATPases throughout the body. And these are responsible for like 1/5 of energy expenditure, and a neuron's up to 2/3. So you can imagine if we don't have enough thyroid, we're going to have quite a significant drop in our energy expenditure that we can expend because we're missing all those fuels. Alrighty, so thyroid disorders. Once again, too low or too high. So too low will be hypothyroidism. And I've got the pathology cutoffs there, which they need to be within the range of. But basically, you're going to have someone who's really tired. They're not really okay with cold. They have no appetite, but they're still gaining weight. Poor hair, skin, nails, low heart rate, just really like decreased metabolic functions and impaired cognition, and all those effects here being basically impaired. Causes can be things like Hashimoto's, which is autoimmune, iodine deficiency, tumors, or iatrogenic, and we'll go through a couple in a minute. And the flip side is hyperthyroidism. So these are going to be someone who's anxious, they're restless, they can't be in the heat because they're too hot already. They're getting weight loss, but they're eating heaps. And the buzzwords are going to be pretypical myxedema, which is, we'll show you a picture in a minute, and exophthalmos. And they'll have like upregulated things like tachycardia, menstrual changes, tremors, and increased gastrointestinal motility. Causes can be things like Graves, tumors, or toxic thyroid nodules. All right, so speak of the devil, Graves. This is one of the core conditions again. So there's basically a TSH receptor antibody, and that's going to falsely activate the thyroid and cause extra hormone production. That extra hormone production goes on to cause a goiter, which is basically thyroid hyperplasia. You're going to present with hypothyroidism symptoms, but they might also have some related autoimmune diseases, and they're more likely to be female. And you also get Graves' ophthalmopathy, pretypical myxedema, and you'll get exophthalmos, which is really one of the buzzwords. Investigations, things like a radionuclide thyroid scan, receptor antibody serology, TPO antibodies, and increased T3, T4. Treatment is antithyroid drugs, radioactive iodine, or thyroidectomy. Alrighty, so on the flip side, iodine deficiency hypothyroidism. There's two different types, both the same mechanism pretty much. So it's congenital, which is where it's due to the mother having a deficiency. And we mostly see this in areas where there's not much iodine naturally. So mountainous areas where the iodine is not supplemented. So pretty much anywhere like the Himalayas, things like that, are more susceptible to it. And there was a question on the exam last year about what condition is screened at birth because of its potentially major effects on the child. And the answer was hypothyroidism. So just know that children are screened at birth for it because it's really needs to be treated early to prevent the irreversible changes. It can cause mental retardation, poor appetite, sluggish growth, decreased heart rate, and decreased temperature. And the other version of this hypothyroidism is just plain iodine deficiency hypothyroidism, but you really need that prolonged decrease in dietary iodine, and you will get excessive TSH secreting, leading to a goiter. And then we've got Hashimoto's disease. We don't know too much about it really, but we believe that it's antibodies against thyroid peroxidase and antithyroglobulin. And that just causes autoimmune destruction of the gland. And the other thing that you can see is a bit of a brief hyperthyroidism when you first get it, just because you're getting like activation, sort of like what happens in Graves with the TSH receptor antibody. But then the thyroid just burns out and dies off. Diagnosis is by antibodies, FNA, histopathology, and treatment is on the basis of thyroid production. Apparently Gigi Hadid has it actually, fun fact. And then here is just a summary of all the different thyroid conditions and what's going to be happening if you have each of these conditions. Go through it in your own time, but it's a super handy high yield table. Alrighty, so treatment. Hypothyroidism we can treat with anti-thyroid drugs like thienamides, but these ones take quite a few weeks to work and they don't really affect exophthalmos, but they do decrease the T3, T4 synthesis. You can't give them to pregnant or breastfeeding women, and it has quite a few different side effects. We can give symptomatic help with the beta blockers, and we do this short term while we're waiting for these to kick in up here. Or we can do that while we're preparing for thyroidectomy or when there's a hyperthyroid crisis. We can also give iodine, which sounds counterintuitive, but high doses actually inhibit T3 and T4 release. That's also for short-term treatment only. And you can have quite a few contraindications like pregnancy, breastfeeding, and toxic nodular goiters. We've also got radioactive iodine, which freaks a lot of people out, but really it's quite safe and it just only targets the thyroid. We use it for thyroid carcinoma, but it's an alternative treatment for hypothyroidism. We only have to do 1 dose and it peaks at 2 to 4 months. Only other problem, can't use it in pregnancy and childhood either. So don't get hypothyroidism while you're pregnant. Last ditch effort is thyroidectomy. And it really just comes down to patient preferences because they'll have to be on lifelong replacement. All right, so hypothyroidism, we can give them thyroxine or T3, or we can do iodine replacement as prevention, which is basically already done by most of our governments with things like supplementation in water and diet. But as when you're pregnant, you need a heap. So it's good to include things like salt, oysters, seaweed, dairy, and eggs in your diet to get that crazy high amount of iodine. Alrighty, so parathyroid glands, we're getting there. So anatomically speaking, our parathyroid glands are like a group of 4 glands. They're each about the size of a grain of rice, and we have 2 different pairs. Your superior pair, which is from the 4th pharyngeal pouch, and the inferior pair, which is from the 3rd pharyngeal pouch. Less relevant until you get to head and neck next semester, so just know that. Histologically speaking, not much of interest, but they're quite distinct from the surrounding thyroid. And these ones will produce parathyroid hormone. And this hormone purely really just exists to regulate calcium homeostasis. It's secreted by the chief cells. It gets secreted as this big 84 amino acid protein and ends up getting cleaved down to PTH 134, which is the smaller N terminal. And it's got a pretty short half-life. We dynamically regulate it between normal levels. So you want to stay within normal levels of calcium. Otherwise, it starts getting hard to regulate PTH. And secretion is secretion is quite a normal kind of situation here, but it gets produced by the chief cells, which increases calcium levels in the blood. Then that increased calcium levels will inhibit PTH gene transcription and release, decreasing PTH and decreasing calcium. So your typical negative feedback. Alrighty, so calcium regulation is like the main point to do with parathyroid hormones. And calcium is really important. We have a hormone just to regulate it by itself, so kind of a telltale sign. But we need it for things all the way from bone and muscle contraction and formation to heart rhythm and all the neurological functions in our body. Our normal levels in the plasma we aim towards is 2.2 to 2.6, and 50% of it circulates free, with the rest circulating protein bound or complexed. So our calcium can be regulated at 3 different sites within the body. So our GIT and our kidneys are 2 of the sites, and they determine the net intake and output, and therefore determine total body calcium, because it's what we're putting in our body and what we're taking out. And that's via absorption versus excretion in the intestines and excretion versus reabsorption in the urinary system. And that's all regulated by hormones. And then we can also have it regulated by our bones. But this is only changing the distribution of calcium within the body, basically how much calcium is in the bone versus in the ECF. And because 99% of the total calcium body is in the bone, this movement of calcium in and out of bones is pretty much how we regulate our serum calcium levels, which we need to keep within this normal level. And basically what happens is that the calcium gets stored in the calcified matrix or the osteoid. And it does this by being deposited in hydroxyapatite crystals, which consists of calcium, phosphate, and hydroxyl. And this is what a bone ends up looking like histologically. So bone remodeling is mediated by 3 different cells. So you've got your osteoclasts, which break down the bone, releasing calcium and phosphate into the blood. And these are upregulated by the binding of rank ligand to rank. And those are upregulated by things like parathyroid hormone, vitamin D, and cortisol. And that's how parathyroid hormone raises blood calcium levels. Osteoclasts are downregulated by OPG, which binds all the rank ligand and stops it binding to the rank. And OPG is upregulated by estrogen. So this is why people who are postmenopausal and have low estrogen have bone breakdown and hypocalcemia. So osteoblasts are the good guys in this situation, well, sometimes. And they come from the mesenchymal stem cells, whereas the osteoclasts come from the hematopoietic stem cells. And osteoblasts actually synthesize the bone matrix, and they put calcium and phosphate from the blood back into the bone. They actually express the rank ligand or OPG, and that depends on what signals they're getting. And then the final cell type is osteocytes, which are just osteoblasts that have been buried in the calcified matrix. And here's our hormones that favor bone formation versus resorption. So things like growth hormone, insulin, IGF, estrogen, and then parathyroid hormone, cortisol, and thyroid hormones. So remember, growth hormone can cause too much bone growth. So you can imagine how it leads too much growth hormone can affect this process and cause too much osteoblast activity. So hormonal regulation of calcium. So parathyroid hormone is the big guy. He stimulates rank ligand. Oh, we've got a question. Why does vitamin D cause resorption? We'll go through that in a second. So basically, parathyroid hormone stimulates expression of rank ligand by osteoblasts and increases osteoclast activity, and also stimulates the formation of 1,25 dihydroxyvitamin D, or active vitamin D. And that increases intestinal absorption of calcium and phosphate. PTH also directly increases calcium reabsorption in the kidneys and increases phosphate excretion. So we're balancing out all that extra phosphate, because remember, when we draw calcium out of bones, phosphate comes with it. When we absorb calcium in the intestine, phosphate comes with it. And we don't want too much phosphate in the body, in the blood. So the cumulative effect is increased calcium levels in both the blood and ECF. And we can see what happens when we increase PTH in the body. So we infuse rats and the calcium goes up high and the phosphate actually sort of drops from a baseline, but they both level out eventually. I didn't get that either. So I don't know why it does that, why it causes phosphate to drop rather than just stagnate. And then dihydroxyvitamin D. This is the question about how vitamin D changes the levels. So it's the active hormonal form of vitamin D. So not only can it increase the expression of calcium transporters and binding proteins, leading to increased intestinal absorption, but it actually stimulates the resorption of bone by osteoclasts. And we'll see that is by how it affects rank ligand expression. So it's one of the things that feed into rank ligand expression, to answer your question about bone resorption. And also facilitates renal reabsorption of calcium and phosphate. So the cumulative effect of this is increasing calcium and phosphate levels. The third hormone is calcitonin, and this doesn't really do much. It's only really active in fish and rats. But despite it having no effect in our body, physiologically, if we give it as a drug, it can inhibit osteoclasts. So we use it to treat Paget's hypercalcemia and osteoporosis. And that one's produced by the parafollicular cells of the thyroid. So that's the other hormone that thyroid glands can produce. Alrighty, so calcium imbalances. So we can get hypercalcemia caused by hyperparathyroidism, which leads to increased bone resorption, calcium absorption, and renal calcium reabsorption. And this basically leads to decreased depolarization and action potentials, because high calcium levels in the serum can block sodium movement through our very important voltage-gated sodium channels. So even though calcium is important for neural function, and you'd think that it causes increased function, it actually causes decreased function. So you're going to get a lot of decreased function symptoms, decreased gut motility, weakness, fatigue, central effects. And we treat it with calcitonin, calcium mimetics, bisphosphonates, and things like that. Hypocalcemia, which comes from loss of parathyroid function, increases the excitability of nerves and muscles, so the opposite effect. And this is where you get Trousseau sign when you put the blood pressure cuff on, and it looks like they've just like shot a basketball with like that kind of effect. So just remember increased activity in playing a game of basketball. I don't know. But basically you can also get decreased bone resorption, calcium absorption, renal calcium reabsorption. We treat it with calcium salts or dihydroxyvitamin D. And this one's the one that can cause seizures and spasms. All right, so moving on to some conditions now, more so than imbalances. So rickets is when we have insufficient vitamin D, leading to decreased calcium and phosphate absorption and deficient mineralization of bone matrix. So because of that, we basically have really soft, like easily fractured bones, and we get bowed legs as a result. You can also get cramps, convulsions, and tetany, but that's really more in the severe cases, and it's not really seen that much. Treatments with vitamin D supplementation and calcium salts, plus minus some surgery to correct the bone and muscle distortion. All right, so osteoporosis. This is like a really core condition. Does anyone know what this is in the X-ray here? You can put it in the chat if you want. But essentially osteoporosis is porous bone, and osteopenia is like the precursor, which is like a low bone quantity. And it's basically occurring because of an imbalance between bone resorption and formation, leading to decreased bone matrix and minerals. And that follows through bone strength loss and increased fragility. Etiology, there's a few different causes, but it's mostly because of decreased estrogen postmenopausally. But you can also get it with Cushing, so increased glucocorticoids and some other medications. And it can also just occur with age, but you really need something else to offset that with only 1.1% lost a year. Risk factors, there's quite a few different risk factors. Not all of them are changeable. And diagnosis, it's often asymptomatic, but you might actually just see it happen with a fracture. So for those of you who had a go at this is actually a crush fracture, a vertebral crush fracture. And one of the most common things we see with osteoporosis, like every second patient on your rheumatology ward will have this. But you also can diagnose it with things like a bone mineral density scan with a T-score. So osteopenia will be a T-score of -2.5 to -1, and osteoporosis is when it's below -2.5. So how do we manage it? Well, first line, we want to manage the risk factors and add in physical exercise, which tends to be the most difficult one in real life to get people to do. So cue the cringy stock photos. Calcium intake, we want to aim for 1,000 milligrams a day, vitamin D, and full prevention. Then if it's not working, we have a history of fractures or a really low T-score, we can look at antiresorptive agents and anabolic agents. So hormone replacement, that one is really just for short term, but it does decrease frank ligand and increase OPG, as we saw. We can get our SERMs, which have an estrogenic bone activity, but don't have that estrogenic effect on the breast and endometrial tissue. So while it has the same effects as estrogen, it doesn't have these risks of breast cancer, endometrial cancer, and hormone-dependent cancers really as much, because it's not having that estrogenic activity there. But it does retain the cardiovascular adverse effects, things like venothrombotic episodes and strokes. So we try to avoid these two really. Our biologics, we've got denosumab, which is the monoclonal antibody against rank ligand. This is the flashy one they like to flash around in exams. But you get a decreased number and function of osteoclasts. And we only really use them when bisphosphonates aren't suitable, because you have the same sort of reports of drawn osteonecrosis and atypical features. The one thing is that it has a subcut every 6 months, so you don't have to really deal with all the annoying treatment regimes. But the reason we don't use it is that it has questionable long-term safety. Then we've got our anabolic agents, which stimulate osteoblast development and activity, decreased risk of vertebral fractures, which is what is most common. But we really just use it when there's a high risk of fracture and other treatments aren't really suitable. So we can't also use it after we've used denosumab, but if we use it before we use denosumab, it works. So the order of treatment also is important. Other problem is we can't use it for more than 18 months because you can get osteosarcoma. So that sucks too. These treatments all suck for various reasons. And then the final one, like the super high yield drugs, are the bisphosphonates. So your core drug is alendronate, and that's the first line for postmenopausal osteoporosis. And it decreases bone resorption by inhibiting formation and activity of osteoclasts, prevents both vertebral and non-vertebral fractures. So a lot of these ones here only decrease risk of vertebral fractures. And your benefits last 12 months after you stop. You give it once a week, half an hour before food. And there's like all these different steps you have to follow to correctly administer it, like sitting up with a full glass of water, or like don't take it at the same time as other medications, all because they're trying to avoid esophageal and gastric irritation, because you can like literally just burn through your esophagus with it. And then your newer version of this is zolendronate, which is like an IV preparation. And we get it once every quarter or once every year. Adverse effects, however, are pretty gnarly. So you can get osteonecrosis of the jaw, which is rare but really hard to treat. Or you can get these atypical subtrochanteric fractures, which are also rare, but it's to do with like the cortical structure and how it's changing the structure of the bone. And you only get that with like over 3 years of use. So because of these like long-term effects, we try to stop them after 5 years for like 1 to 3 years. So you end up with 2 years after that effect wears off where you can't really get any benefits from this drug. All right, so endocrine pancreas. So absorptive post-absorptive state. This is like relevant when we're talking about like the effects of glucose and glucagon, but just know the difference between each state and what's happening to each fuel at each time. So structure of the endocrine pancreas. So it's like the endocrine component is composed by the islets of Langerhans. A niche thing you might need to know is that they're like 1 to 2% of pancreatic mass. 70% are beta cells secreting insulin, 20% are alpha cells secreting glucagon. You have some delta cells which secrete somatostatin. If anyone can remember what somatostatin does, bonus points. But it also just fine tunes insulin glucagon secretion, spoiler alert. And then we got the polypeptide cells, which secrete pancreatic polypeptides. And here's what it basically looks like on a legend. Other anatomy, rich supply of capillaries and SNS and PNS neurons, which helps control and release the new hormones. And that's what it looks like. And you might get a histology picture and have to like label what that is. So do know what it looks like and be able to recognize it. And the star of the show with the pancreas is, of course, insulin. And the other thing that you need to know about insulin that's a bit niche is that C-peptide is produced alongside insulin because it's cleaved from pro-insulin with insulin. And that happens inside B cells. So there was a question last year about like, oh, what can be measured alongside insulin to see if it's like endogenous insulin or exogenous insulin? And the answer was C-peptide because it's a side product of insulin production by the beta cells. So do know what C-peptide is. But yeah, insulin's metabolized by the liver and kidney and promotes glucose uptake, glycogenesis, lipogenesis, and protein synthesis. Secretion, increased blood glucose will trigger GLUT2 receptor transport to glucose into cell. It's converted, increased glycolysis and ATP production, closes the potassium channel, and then cell membrane depolarization. Basically, just go through that, and basically it just picks up high blood glucose. The cell will react and secrete insulin. That's really all you need to know. If you want to learn the steps in between, go you. And obviously there are factors that promote and downregulate secretion. So increased amino acid concentrations, parasympathetic activity will promote insulin. Incretins, which are produced by the gut after you eat, and sympathetic activity will downregulate secretion. All right, so what does insulin do? So it acts via the insulin receptor, which is the tyrosine kinase. And once it activates that, it has a signaling pathway, which basically goes down to AKT, which orchestrates the metabolic actions of insulin. And there's some questions in the chat, which I'll answer later. And it basically, AKT basically orchestrates all these metabolic actions of insulin in hepatocytes, skeletal muscle, and adipocytes. Glucose transporters, there's 4 different types of glucose transporters that insulin can act on. So we'll see one of the effects of AKT is GLUT4 translocation. But basically, these all just mediate different types of glucose uptake. So GLUT1 is for basal uptake, and it's important in the brain. GLUT2 is like low affinity, so it mediates uptake of glucose into cells when we have hyperglycemia, and that's major transporter in liver, intestine, and kidney. And GLUT4 is the main one, and that's in the muscle and fat, and it's inside cells and only functions in the presence of insulin. So your GLUT1 and 2 transporters are going to happen when you have sugar in the blood, regardless of insulin. And GLUT4 is the one that's triggered by AKT as part of the insulin signaling cascade. And that's the one that causes glucose import in response to insulin, and is the main one you need to know. So the actions of insulin. So essentially, in the absorptive state, it inhibits catabolic pathways, so all of these processes, and stimulates anabolic pathways. And you can see the effects that flow through as a result of that. All right, so glucagon, the opposite of insulin. So glucagon is a polypeptide hormone that's rapidly degraded by the liver and kidney. Its actions are in the postabsorptive state. So it acts on the liver to stimulate glycogenolysis and gluconeogenesis, and also the synthesis of ketones, which are the starvation fuel. It also possibly stimulates fat breakdown, but we don't really know if it does. But overall, its net effect is to increase plasma glucose and ketone levels to prevent hypoglycemia, and that's what we use it for clinically. So there's factors, once again, that promote secretion, and there's factors that downregulate secretion, and you should know these as well. Our body requires about 10 grams an hour of glucose, so between eating, our glucagon manages that requirement. And this sort of is how it does it. So just go through this diagram in your spare time if you have time. All right, so glucose counter-regulatory hormones. So glucagon isn't the only hormone that goes against insulin. There's also epinephrine, cortisol, and growth hormone, but glucagon just happens to be the main player. Don't really need to know much about it, but basically just know what each of these hormones can have an effect on. So when things go wrong with insulin and the endocrine pancreas, we end up with diabetes mellitus. And that's just a disease characterized by hyperglycemia from relative or absolute deficiency of insulin. And it's not the same as diabetes insipidus, which is from ADH secretion problems. Just know that because people mess it up for some reason. It affects 1 in 10 Australians and a few more males and females, but it costs a heck of a lot of money to the Australian government. So it's good to reduce it if we can. Type 1 makes up 10%, and that's when the body doesn't produce enough insulin, generally autoimmune based condition. But most of them are type 2, which is non-insulin dependent, and that's because the body becomes resistant to the effects of insulin. You can also get gestational diabetes, which is like a temporary pregnancy condition, and it's relatively common. Diagnosis is with the glucose tolerance test, but more recently we use HbA1c or glycated hemoglobin, and that's more of a long-term, like 3-monthly measure of glycemic control, and we want to aim for like 5.7 or less. So type 1 is the beta cell destruction mediated by cytotoxic T cells. So it's autoimmune. And alpha cells are spared and can secrete too much glucagon, which can further the impact. It's slightly genetic based, so we get a 50% identical twin concordance. But there's also risk factors, including things like respiratory infections, enterovirus infections, rapid weight gain, toxins, hygiene hypothesis. Basically, we don't know exactly what it is, but it could be a range of factors that can cause it. And the consequences are summarized in this little diagram here. But essentially, we have an insulin deficiency and a glucagon excess leading to things like fatigue, decreased glucose uptake, lipolysis, starvation, so ketones and ketogenesis and things like that. So you can go through each of them in your spare time. But the main one to know is acidosis, and we'll go through that in a minute. Type 2 diabetes mellitus, on the other hand, is super common. Like 1 in 3 people by 2050 will have it. and there's a strong genetic predisposition. So 90% identical twins have it. And it's caused by things like obesity, physical activity, hypertension, dyslipidemia, and things like that. Basically, what happens is that the signaling pathway leading to GLUT4 translocation, so the one that responds to insulin, gets compromised. And we think that's by things like lipids being in the cells when they shouldn't be and too much of it, or activation of inflammatory pathways in the muscle or liver. So because we've got less GLUT4 traveling to this membrane, less glucose gets taken into the cell in response to insulin. So that's where the insulin resistance comes from. Initially, our beta cells are like, all right, well, we just compensate. So they'll produce all this extra insulin, but because the resistance keeps progressing regardless of this, the cells become more resistant. The beta cells have to start producing more insulin to keep up. And while they increasingly compensate, eventually they burn out and stop working and insulin production declines. And then we get even less glucose taken into cells. So to compare type 1 and type 2, I've got a little table here that you can go back to revise later. But we'll go on to the complications of diabetes. So this is basically how they'll present or have as acute complications. And for diabetics, these can pretty much happen every day. The orange ones are going to be more common in type 1, but the rest are pretty much all going to be in type 2 as well. And they all result from a profoundly catabolic state. So not enough glucose getting into cells. So we're like having to break down fats and proteins and things like that. Got some notes about Kussmaul breathing and acetone if like you don't understand why you get those. But a useful activity that you should do is go through each of these presentations and just learn exactly why they are, like the mechanism behind it. And then like third year will be a breeze for you. All right, so diabetic ketoacidosis. This is like the really serious thing that happens with type 1 diabetes. And it happens if you've poorly managed it, but also if you've got just increased demands on the day or your body's stressed or something like that. And what happens is basically the body uses all these fatty acids and proteins as glucose can't get into the cells. And they're getting converted into ketones so that we can use them for starvation. And because ketones are acidic, they can induce a metabolic acidosis, which is really not good. So how it can present is with Kussmaul breathing, which is like deep, really labored hyperventilation. And it's your body trying to breathe off all the excess CO2 and compensate for that acidosis. And then you get like pretty much all your really bad diabetes presentations and symptoms, but like plus. And you can also get neurological things like cramped legs, blurring vision, confusion. You can smell the acetone, which is just the ketones on them, tachycardia, hypothermia, pretty bad things. You also get hyperkalemia, and like potassium imbalances are really bad for the heart. And that's just a compensatory mechanism for the ketoacidosis. And we get HAGMA, which you guys would have seen from the last lecture. I don't know much about the HAGMA and LAGMA, whatever it is, but basically it occurs from excessive keto acids. Treatment is a fluid resource, short-acting IV insulin, replacement potassium, and glucose supplementation. I'll check the chat. Why wouldn't type 2 diabetes normally have DKA? Awesome question. So type 2 diabetes doesn't have ketoacidosis because the body's still producing some insulin because of that beta cell compensation. So it can happen, but it's rare because there's some insulin still being produced. Whereas with the type 1, it's autoimmune. So we just have latent beta cell destruction, and there's no insulin produced whatsoever. So the body has to go into starvation mode. Why is there replacement K plus if hyperkalemia results? So hyperkalemia is caused by the replacement potassium. Oh, I see. Yeah, replacement of potassium. I don't know. I think that might be just an error, to be honest. I'll check back because I just took this from the lecture notes. So they might have just made a mistake. About the blood. I don't know. I'll have a check, but it could be that it causes hypokalemia or something like that. But I'll go through it at a later point. Cool. So I'll get back to it. So chronic complications of diabetes. So you've got microvascular and macrovascular. complications. So your microvascular complications are characterized by vasoconstriction, increased capillary permeability, and the proliferation of your extracellular matrix and capillary occlusion. So basically, like, all your vessels get really messed up, and there's a really high predisposition to atherosclerosis. So that can lead to things like cerebrovascular disease, coronary artery disease, and peripheral vascular disease. And peripheral vascular disease is really nasty. So that's diabetic foot. And that can lead to things like ulceration, gangrene, and even amputation. And like not surgical amputation, like it amputates itself. It's really, really nasty. And it really needs to be prevented in diabetics. But the main problem is that people with diabetes are 2 to 4 times more likely to have heart disease or stroke, and it ends up killing 2/3 of them. So if we can prevent this, that's like bonus. Macrovascular complications are kind of like a result of the microvascular complications. We can get eye disease, nephropathy. So you get diabetic nephropathy, and that causes albuminuria and kidney failure due to increased glucose in the filtrate, increased urine excretion and renin secretion, leading to vasoconstriction of the renal arterioles and infarction of the surrounding tissue. So basically it causes like renin to be secreted, and like this vessels squeeze up and stop supplying the kidney, and you get nephrotic patches in your kidney. And you also get neuropathy. It's not only just from the high glucose levels directly damaging them, but because like the blood vessels, they die off, and then the nerve doesn't get supplied and your nerve dies, which can also lead on to more macrovascular peripheral effects. So like if you can't feel your foot in your shoe and it gets an ulcer, you're not going to be able to stop like diabetic foot happening as easily. So it's a bit of a triple whammy. Macro and micro. Have I switched macro and micro? Don't think so.
I just mean in the like just the heading there, Mike. Like you see, I go back to the other slide. Sorry, there. That's microvascular, isn't it? Go back. That's macro, and the other one's micro, isn't it?
That's
all. Because
I don't actually think. I think
micro.
So the idea behind macro and micro, I think, from what I was seeing, was that macro is like the things you actually see. So like the eye disease, the nephron disease, and neuropathy disease, whereas you can't really see micro because it's just the blood vessels. But I'll double check because that's a very good point.
I'll have to check too.
But I think that was the idea behind calling it micro, but it could easily be the other way around.
All right, thank you. Appreciate that.
Yeah, no, very good question. Because I'm not sure either. Yeah, that's all for questions. Cool. And basically diabetic nephropathy is the most common cause of CKD, and it's actually the leading cause of death in people aged 50 to 70 with diabetes. So it's a bit weird between that and cardiovascular disease. And your symptoms of the neuropathy can depend on where you're getting effects. So like pain, numbness, pain and numbness is like everywhere. But if you've got it in like your splenic nerves that affect digestion and things like that, you can get digestive problems or even heart issues with like the nerves that affect your heart. So it's not just like the nerves in your peripheries. All right, so treatment depends on the type of diabetes you have. Type 2 starts with like diet and exercise. Then we move to like oral hypoglycemics, so metformin, and then insulin if we can't really manage it. But that in reality, that can be all over the place, and it's not really that neat. Type 1 is insulin and dietary modifications. Just know this diagram here, that's really helpful, and they like that one. So insulin can be prepared in multiple ways. You've got your short-acting, ultra short-acting, intermediate, long-acting, and then you've got like a mixed preparations, which is what we really use in real life. But the goal is just to replicate physiological secretion with a bolus one at meal times and basal for overnight or fasting. You can get problems of hypoglycemia if you give too much insulin or your body doesn't need as much insulin and things like that. So that's why diabetics have their little jelly beans. And you can get antibody formation to foreign insulin, which is really quite rare. Or you can get local allergic reactions. And then precautions is that requirements are quite easily changed. And so you have to adjust doses. And then your administration is pretty much patient preference, but you've got syringes, pen injectors, or if you've got a spare $5 to $7 grand laying around, you can get one of these cool little auto injectors, which like monitor your blood glucose and carbohydrates and pre-program a basal rate with your bolus dose just determined by the user. And these ones are really great for avoiding complications and improving quality of life. What you need to know from this one is just know this table quite well. You will get quizzed on it. The mixed ones aren't really as relevant, but it's still good to have a general basic idea. All right, so oral hypoglycemics, or step 2, and this is for type 2 diabetics. So metformin, everyone's on metformin, and that's the first choice unless you have renal impairment with like diabetic nephropathy and things like that. So it increases the sensitivity to insulin, but doesn't stimulate insulin release. We actually don't know how it works, which is ironic, but it can be used in combination with sulfonylureas and insulin, and it has a low risk of hypoglycemia. Can cause weight loss, nausea, and diarrhea, but that's pretty much all of them. Sulfonylureas, glucoside, another core drug. This one actually stimulates insulin release from the pancreas. So you need to have some functioning B cells. So therefore it's more useful in the early stages of diabetes. Side effects, hypoglycemia, high protein binding, and it can cause weight gain via possibly stimulating appetite. Then you've got your incretin mimetics, so exenatide, which just mimics the incretins. That can cause quite a few side effects, but it's not really a core drug, so you don't need to know too much about it. What you do really need to know is the incretin enhancers, so sitagliptin, and that's a competitive DPP-4 inhibitor. So therefore it prevents the incretins getting metabolized, and these can stimulate insulin release and decrease glucagon secretion. It doesn't cause weight gain, but it's only PBS listed for dual therapy with metformin or sulfonylurea. And it's like more for refractory glycated hemoglobin levels, so that aren't being helped with just metformin or just sulfonylureas. This one can also cause hypoglycemia, headaches, and MSK pains. So none of them are perfect. We've got more options if we don't want to use any of those, but these ones aren't really core drugs. I think acarbose is though. So you've got your insulin sensitizers, which increase tissue sensitivity to insulin and transporters. And they act via the PPAR gamma. But these ones have a slow onset. There's low hypoglycemia risk with monotherapy, but then they're only listed for dual therapy in combination with sulfonylureas or metformins. And it can cause things like weight gain, fluid retention, and it's questionable long-term safety. So it's not really that useful. Otherwise, we've got our sodium glucose cotransporter 2 inhibitors, which increase renal excretion of glucose, and that's by blocking the proximal tubule, which is responsible for 90% of reabsorption. So we're getting rid of glucose through the kidneys, essentially. But there's a low risk of hypoglycemia, decreased weight, and there's only really a risk of hypoglycemia when used in combination. So those are some positive effects. Side effects, not great for long-term safety. We don't really have much data on it. Efficacy really depends on adequate renal excretion. And when like most people with diabetes have renal problems, it's not really going to be that helpful. It can increase urinary glucose, so things like intention, UTIs, vaginal candidiasis, all extra problems that we don't want to have to deal with. So they're not really like that helpful either. And then finally, we've got acarbose, which is an alpha glucosidase inhibitor, which is useful when our postprandial blood glucose is high despite dietary modification. And it's more like an adjunct to diet and exercise that's not controlled by other drugs. So it's not really first line, essentially. It's not associated with weight gain, so that's a positive, especially when we have obese patients. And it reduces carbohydrate reabsorption, leading to postprandial increases in blood glucose. Side effects, flatulence, and diarrhea. So yeah, your main ones to know are like your metformin, glucosides, sitagliptin, and if you know like these ones, you should be okay. Just roughly know the rest of these. Here's a nice little summary. Just a tip with pharmacology, even though like you have your set of core drugs, the ones that aren't core drugs, they will still get chucked into your questions, but they'll be like decoy answers. So you have to have a rough idea of what they are, because they'll still be on your exam. They just won't necessarily be the answers. And here's a quick little overview for you guys to use as a summary. This is pretty helpful, and it's what I'd recommend going off for memorizing before exams. All right, so just finally, the adrenal glands. So they're located on the medial aspects of the upper poles of each kidney in the retroperitoneal space. Your right gland's like a pyramid, your left gland's like a semi-lunar shape, not really relevant. innervated by the celiac plexus and the greater splanchnic nerves, and they drain to the lumbar lymph nodes. Blood supply comes from the adrenal arteries, and there's 3 of them, and they all come from different parts of the vascular supply. So inferior phrenic, abdominal aorta, and renal arteries. And I think there was like one question one year in anatomy, like there's a blockage of like a renal artery, like what might be impacted. It was like part of the adrenal gland. So just roughly know what the blood supply comes from and what the effects of like no blood supply to a certain part of the vasculature could cause. Not that high yield. So structure, this is high yield. So there's a fibrous layer covering it, but below this you've got your cortex and your medulla. And within your cortex, you have 3 layers. So you have your zona glomerulosa, your zona fasciculata, and zona reticularis. And these ones are secreting hormones in response to ACTH. And each one releases a different type of hormone. In theory, these are like glomerulosa releases this, fasciculata releases this, reticularis releases this, but there's some overlap in real life. But for the purpose of exams, just know what each one releases and just assume there's no overlap between the zones, just to save your head the trouble. And then we have our medulla, which have chromaffin cells, which release catecholamines, which are down here. And the adrenal medulla actually comes from neuronal tissue and is part of the ANS, unlike the cortex. So what you need to know about histology is basically just be able to recognize each layer. So if you know what each layer looks like on histology, you should be fine. And then you just need to know what each layer emits. Alrighty, so these are the hormones produced by the adrenals. You can go through this in your own time, but you basically got your mineralocorticoids, your glucocorticoids, your androgens, and your catecholamines. And this is what happens if we have too much or too little, which we'll go through in a minute. So adrenaline, to start off with, is the big boy for content-wise. It's synthesized from tyrosine, and the rate-limiting step is the conversion of tyrosine to L-DOPA, and it's stored in the vesicles of chromaffin cells and released in response to neuronal stimulation about stress. So if you perceive or actually have stress physically or mentally, you can get nerve impulses going through to the medulla and causing release of catecholamines. When they're released, 80% is adrenaline and 20% is noradrenaline. Adrenaline is less specific and stimulates alpha and beta receptors, whereas noradrenaline acts specifically on alpha receptors. And that's really the only difference. Its actions is essentially the fight or flight response. Right, so cortex hormones in general. So remember that I said the cortex responds to ACTH and releases the 3 different hormones depending on which layer it is. How it determines which hormone it's going to release when it gets ACTH is kind of determined by which precursor gets followed in the path of production. So all the hormones start with cholesterol, but depending on which enzyme is present, it can go down a different path. So they all go to progranulone, but if it goes down to like deoxycorticosterone, it's going to become aldosterone, and so on. Circled are the committing steps to each production chain. It's just handy to understand where they break up. So the cortex hormones, they're part of the hypothalamic-pituitary adrenal axis. So I've just added adrenal to the axis that we discussed in the beginning of the lecture. So it's basically circadian rhythm and stress causes production of ACTH. ACTH binds to melanocortin-2 receptors in the cortex and stimulates steroid hormone production by increasing the activity of those enzymes I discussed. And cortisol will have negative feedback. So ACTH. So it mainly leads to cortisol production, despite all 3 hormones being produced in response. And this is just because of like the effects that ACTH has on the enzymes. Just know that it's mostly cortisol production. Some androgens are produced, but androgens mainly come from the gonads anyway, so the adrenal gland's not like a major source. And aldosterone is only minorly regulated by ACTH, so it's not really impacted. ACTH can also bind to melanocortin-1 receptors on the skin, which is why you get pigmentation happening when you have excess ACTH. All right, so cortisol. So this is the one that's caused by ACTH secretion. And ACTH does this by 1, increasing the concentration of cholesterol in the inner mitochondrial membrane, and 2, increasing production of the enzyme that causes the committing steps to cortisol to occur. Circadian rhythm and cortisol awakening response are the main variations in production. So basically ACTH is like secreted in a big bolus right before you wake so that your cortisol is high when you're awake in the morning, causing you to go get breakfast and things like that. Transport is primarily bound to CPG and is deactivated primarily by the liver. It acts via glucocorticoid receptors, but can also affect mineralocorticoid receptors if levels are too high. And that's when you can get aldosterone effects with glucocorticoids. It also diffuses across the cell membrane, translocates the nucleus, and activates genes for protein synthesis once it's gone through those glucocorticoid receptors. Actions are basically catabolic, anti-inflammatory. It can increase the SNS. It can have effects on the bone, brain, heart. It can have hypertension because of its effects on aldosterone receptors. It can promote fetal development. It can promote growth, and it can decrease function of the reproductive axis. So there's a lot of different effects, and unfortunately you have to know most of them. So just go through that list and understand how it does each one. All right, so when things go wrong. So Addison's disease is adrenal insufficiency, and it's primary, and it's the loss of adrenal cortical function, normally due to immunosuppression. Because all cortex zones are affected, aldosterone levels are also decreased, causing low blood pressure. Presentation, weakness and fatigue, loss of appetite, weight loss, that skin pigmentation because of the effects on the receptors, low blood sugar. Treatment is oral glucocorticoids and mineralocorticoids. Cushing's syndrome is where there's too much cortisol, and you can have primary, which is where there's a cortisol secreting tumor of the adrenal gland. Secondary, which we call Cushing's disease, not syndrome, which is an ACTH producing tumor of the anterior pituitary gland. Or most commonly, it's just someone's using exogenous corticosteroids too much. Pathophysiology, excess cortisol leads to catabolism of bone, muscle, skin, and other organs. The catabolism causes increased blood sugar levels, which is why you get like a diabetic effect. Your fat distributes to your face, trunk, and back. Cortisol can cause an appetite increase, causing obesity, and immune suppression and hypertension also can occur from cortisol, leading to those effects. So you get the very, very specific Cushing syndrome effects, and you will be able to spot them like that, and you need to be able to spot them like that on the exams, and that's all of them listed there. Special investigations is the dexamethasone suppression test to find out whether it's Cushing's disease, primary or exogenous, which we'll go through next. And treatment is surgical removal of the tumor or cessation of corticosteroid treatment. So it really depends on the cause. This is the dexamethasone suppression test. Basically, we give them dexamethasone in a high and a low dose and see how it affects the cortisol levels and how the cortisol levels go on to affect the ACTH levels. Just know how to determine which is the cause based on your results, because they will give you a result list and say, okay, what caused his Cushing's? All right, so hypoaldosteronism, usually due to an aldosterone producing adenoma or idiopathic hyperplasia of the gland. And you'll get hyponatremia, hyperkalemia, and then that will lead to things like hypertension, arrhythmias, alkalosis, and hypocalcemia, polyuria, and nocturia. How do we treat it? We take out the adrenals, or we give them aldosterone receptor antagonists. Fun fact about hyperaldosteronism is I think it's 2 to 10% of people with refractory hypertension just have a adrenal incidentalloma. So just a benign tumor of the adrenal adenoma, a benign adrenal adenoma, which is producing this aldosterone. So you can cause hypertension with no identifiable cause, and that will be the cause. And it's still an area that people are investigating now. All right. So congenital adrenal hyperplasia, you will almost certainly get a question or two on this in the exam, always comes up. Pathophysiology is kind of complicated, but basically there's a deficiency of the synthetic enzymes that we would need for cortisol and aldosterone production. So if we go back to here, we don't have the right enzymes to go down these paths. So what happens? Usually it's a 21 hydroxylase deficiency. And as these can't produce cortisol and aldosterone, we start shunting towards androgen production. And because this often happens congenitally, you'll end up with adrenal hyperplasia, and it's going to be a little girl who has undifferentiated ambiguous genitalia. So a little girl, we don't actually know. And basically what happens is, in addition to the ambiguous genitalia, you'll get salt wasting and a failure to thrive. So it's really important to treat it. Hypoglycemia. If they have it happening starting later on, you can get early age pubic hair, accelerated growth, and skeletal maturation. So we can see kind of the pathway that it goes down here. Like don't have hydroxylase, don't have hydroxylase, don't have hydroxylase. So it's going to go back up and around, and we end up going down this pathway to produce the androgens. It takes a while to understand, but just once you go through it, it'll make sense. We diagnose it based on an elevated 17-hydroxyprogesterone level. And that's just the mechanism there, which you can go through if you want. And treatment is via hormone replacement therapy, and just really like working to fix these imbalances here. And I don't know if you guys got the medicine of the mind lecture on it, but correcting the ambiguous genitalia is a hot topic for discussion ethics wise. So we don't always do that necessarily. Right. Pheochromocytoma. It's just a catecholamine secreting tumor of the chromaffin cells in the adrenal medulla, which basically means that there's a prolonged fight or flight response. And that's what they look like. Pretty specific. Presentation going to be, basically they're going to be super stressed out, too much sympathetic stimulation, facial pallor, flushing, headaches, palpitations, anxiety. And you diagnose it by increased concentrations of fractionated catecholamines and metanephrines in the blood, or a 24-hour urine collection. And we can also use a CT or MRI to localize the tumor, and we have to surgically remove it. All right, finally, it's clinical skills. So I'm not going to go through the entire clinical skills textbook because that's not useful at all for you guys in the written exam. But basically what I'd recommend is go through Talian O'Connor's clinical examination, so the textbook. I've got the Google Drive link, but it should just be under textbooks if that link doesn't work. Read through chapters 27 to 30 and actually do it, because it has a lot of these things that they end up putting on the exam. And that mostly comes from chapter 29, which is the correlation between physical signs and endocrine disease. So you'll get a question, it'll be like, a woman's come in with these symptoms, and this special test was positive, or she had these signs and symptoms. What is her pathology most likely to show? So you've got to kind of go through multiple steps, like knowing the signs and what that sign is indicating. So for example, if it was of hyperaldosteronism, and then knowing what the pathology results of hyperaldosteronism might show. And that was something that really shocked me in the exam last year, because I was used to like the very low level questions where it's like, oh, what enzyme does this? And suddenly they're like presenting with these multi-level clinical based questions. So reading through that chapter will be really helpful there. Otherwise, just know any like of the special tests or investigations, like knowing how to do Trousseau sign, because that's the kind of things they're more likely to test you on, rather than knowing exactly every step in the examination. And then in your MONSCIs and OSCEs, just think about why you're doing a history and exam, and don't just memorize all the questions and examination steps, because that's not very helpful. So in history, remember that you're asking about risk factors, symptoms, and impacts of your differential diagnosis. And in an examination, you're looking for signs of disease, and that should help you remember what you need to do and help you know which system reviews to do. So basically just shaping your history and examination around what you're looking for. The system review questions, I've got them listed here. If you like them, what I used to do was just put it in a little checkbox for my MONSCIs, and I could just tick off what things they said they had. And then if you want signs and symptoms and things you're looking for in examination, I've got the summary sheet. It looks like this, basically a brief description of each condition and all the things you're going to be looking for. And that's the Google Drive link. Message me if you have any problems with that. Alrighty, so what now? Just some tips for me for examination preparation. Please start doing practice exams ASAP, because that is the #1 mistake people make, and you just want to get used to like answering the questions. Alrighty, the last couple questions, there was a long question from Vanessa that I will just go through now. So if vitamin D increases absorption of calcium from intestines and osteoclast activity, then why does low vitamin D cause weak bones? Okay, cool. Wouldn't there be a decrease in bone resorption with low vitamin D? So we'll go back to it. Where are we? Yeah. And bone resorption. Yeah, cool. Okay, so vitamin D levels. So vitamin D stimulates binding of rank ligand rank. I think vitamin D can have, so I remember vitamin D's impacts are like twofold. So it causes hypercalcemia, essentially, if we have a look here. So yes, it does cause a bit extra bone breakdown and calcium being released into the blood, but it also has these effects on intestinal absorption. And the net cumulative effect is increased calcium. So kind of think of it like balance. So yes, there's one negative effect where it causes calcium to leave the bones and go into the blood, but it's also increasing your total body calcium via the renal reabsorption and the intestinal absorption. So you still need lots of calcium for managing your PTH levels. So if you have hypocalcemia, PTH is going to draw a heap of calcium out of your bones anyway. So you need that vitamin D to keep your calcium levels high so that your PTH is regulated and not pulling all the calcium out. So yeah, it's kind of counterintuitive, but the net effect is that it causes more calcium in the body than it's drawing out of the bones, if that makes sense. If not, I can explain it again later. Yeah, cool. So is too much vitamin D actually detrimental to bone growth? No. I guess if you had crazy high amounts, but you'd also have super crazy hypocalcemia, so you have bigger issues. Replacement. Cool. Any other questions? Oh, cool. Alrighty. Well, that's it from me, guys. If you have any other questions, feel free to message